I want to welcome everybody to this evening's very special presentation. It's basically a real honor, because not only are we going to be addressing a very germane topic to our profession and something that's really taken off over the last decade, but we have an absolutely superb individual, one of the most knowledgeable individuals in this area to present on it. So we're really going to have a great evening. And before I get in and introduce our keynote speaker tonight, I'd like to welcome my co-moderator tonight, Alex Hank. And Alex is a perfusionist in Augusta, Georgia, working at Children's Hospital down there, and is actually a graduate of David Fitzgerald's program, which we'll talk about in just a second. My name's Al Stammers, and as mentioned, Alex and I will be doing the co-moderating. Just a few housekeeping details to go over, and if you participated in these webinars, 20th, before, you know that the standard format that we follow. Please stay logged in, and this is a no-brainer. I mean, I don't think anybody would dare miss a minute of tonight's presentation, but you know, there is a recording for 45 minutes or more to stay on. The post-survey, I'll show you in just a second. It's a very, very easy one to do. The CEUE certificate, our educational office will mail these out to you, email them to you, excuse me, usually with a week's time. And if you don't receive it, at the very last slide, we have Alex and my emails. Please get in contact with either one of us and we'll make sure that you do get it. And then, of course, we post these presentations on YouTube. The survey that's going to be completed is just 3 questions, and you can always solicit new topics and subject matter that you want to have addressed in webinars. We really appreciate getting that particular feedback. I think everybody knows the question and answer session. This is a typical Zoom function in the Q&A box, the icon either at the top or bottom of your screen. Please use that. Alex and I will be looking at that. And as you see questions come up, if you like that question, please hit the like button. You don't have to subscribe, just hit the like button, and then that will elevate it up the rank in regards to a Q&A. So with that, it is my pleasure to introduce our speaker this evening. I've known Dave for numerous years, and you know, have nothing but the highest admiration for what he is and has accomplished throughout his career. So I'm just going to give you a little bit of a brief background on Dave. Dave received his bachelor's of science in biology from Bloomsburg University, and then went on to Drexel University, where he received another bachelor's degree in cardiovascular perfusion sciences. His master's in public health was got from the Alaska Anchorage, University of Alaska in Anchorage, and he did a program. His thesis practicum was an evaluation of the Living Well with Diabetes program in Prince William County, VA, which we'll hear in a second, is where Dave worked for many years before his current position. And then over 3 years ago, Dave picked up his Doctor of Health Administration. And if you really want to read a good paper in the Journal of Thoracic and Cardiovascular Surgery, this is where David had published his paper. I highly recommend that you look this up. It's a phenomenal paper and very, very interesting. Dave is a division director at the Cardiovascular Perfusion Program at the Medical University of South Carolina. He's been on faculty there now for 7 years, and just the last few years became the director there. He also worked for many years in Fairfax, Virginia at the Inova Health Systems in Falls Church. And he had many hats when he was at that facility. Not only was the director of perfusion, but he was also running a number of campuses all across Virginia and Maryland. We don't have time to go through his awards and achievements. They're numerous, and you know, with the pinnacle of the Gibbon Award several years ago, as well as multiple awards from multiple organizations. And he's been actively involved in all the perfusion organizations, both nationally and abroad. Not only AMSAC in the Academy, but also in the Focus Initiative on safety. He's been published papers at the Minimally Invasive Cardiothoracic Surgical Forum and many others. He's written numerous publications, book chapters recently in the Extracorporeal Circulation, texts that came out, and of course, numerous abstracts. So, and we're very fortunate because the topic that Dave is going to present tonight is oxygen delivery as a key quality indicator. And why that is so important, I think that as we've shifted and paid more and more attention to the adequacy and the optimization of perfusion, this has really come out as one of the pinnacles, something that we could use and manage very easily, or at least effectively in our practice patterns, because of the ease of measuring this, especially with electronic data collection systems. So with that, I am going to shift now to Dr. Dave Fitzgerald, and Dave will take control of the screen and present with his ongoing presentation. David?
Oh, thank you, Al. Thank you. Thank you for the very kind words. It's a privilege and an honor to be here today, presenting to you on a topic that I don't consider myself an expert in per se. There are individuals that have worked in this ethos probably for the last 15 years, carrying the torch for oxygen delivery by the names of George Justison and Rob Baker and Philippe de Sommer. I became very passionate about the topic, of course, in a perfusion education program, because I think it's fundamental for incoming perfusionists to have a better understanding about perfusion adequacy and some of the key parameters that are now becoming available. So thank you again, Alex and Al and the rest of the planning committee for this webinar, for inviting me here today. Just before I got on, I'm here at my workplace, and I went out to the restroom and didn't realize that my office door closed behind me. And so I was locked out for a few minutes until I was able to find security to bring me back into my office. So I don't know if I was going to be here in time if security got here, but nonetheless, my disclosures for this, for the next 60 minutes in sharing with you today, I work here at the Medical University of South Carolina. I do work with AMSEC University. However, I don't have any financial disclosures relative to this topic. And I really want to touch upon, three key points about oxygen delivery as that key indicator. The science behind it, the principles, the biochemical principles behind oxygen delivery, its association with post-op cardiac surgical outcomes. And then I want to spend maybe about the last third of my time, sharing with you some ideas or concepts in terms of how you could make this a key quality indicator at your institution if you're not already prescribed to the idea of monitoring oxygen delivery. Kind of, what were the key items that you can take home to your program at the local level? And so this textbook you see here to the right, this is one of the first textbooks with regard to cardiovascular perfusion. This was Pierre Galetti's heart-lung bypass. In fact, I have a copy of it right here. My copy doesn't look as bright as the one that you see here on the slide, but this was printed in 1962. And in the introduction section, I took a statement here on your first bullet point that a well-designed artificial heart-lung machine should be able to maintain undisturbed cell function throughout the organism. And, for a century before John Gibbon had his very first successful case, which, we just spent last week as the anniversary of cardiopulmonary bypass, they've been working on models to be able to replicate extracorporeal support, albeit in experimental animal models. But if you were to ask perfusionists how they determine the adequacy of perfusion parameters, you may hear a lot of people refer to venous saturations on bypass, or perhaps acid base and co-oximetry, serum lactates if they're available, even prescribed indices on, if we're normothermic, we're at least a 2-4 index. If we're cold, perhaps a little less than that. And then near infrared spectroscopy. But within the last 12 to 15 years, you've heard more about the idea of measuring oxygen delivery. And then I'll spend a couple of moments towards the end talking about more cellular respiration components like oxygen delivery, based on a ratio of the patient's VCO2, some of that, microcirculatory levels of understanding of adequacy of perfusion and tissue gas exchange. Most of the science that you see in oxygen delivery pertains to the kidneys. Acute kidney injury is, as you may know, is one of the most common major complications of cardiac surgery. Think for a moment that, there are over 2 million cardiac surgeries that are performed worldwide, and the rate of cardiac surgical associated AKI, acute kidney injury, varies from center to center between 5 to 42%. And cardiac associated AKI is the second most common cause of AKI following sepsis. And it is independently associated with increased mortality and morbidity. When we look at this systematic review from O'Neill and colleagues, you can see here, you can see here that these are the risk factors, both pre-op, peri, and post-operative risk factors that are associated with AKI. We can't really control many of the preoperative variables, can't certainly control somebody's age or gender or the chronic illnesses that they bring to the operating room suite. But we have some influence over the intraoperative procedures, especially a perfusionist, the hematocrit during cardiopulmonary bypass, hypoperfusion, perhaps venous congestion or hypovolemia. These are things that as a practicing perfusionist, we have influence over. Why is the kidneys become really ground zero for the adequacy of perfusion or oxygen delivery? Because even the smallest changes in a patient's serum creatinine postoperatively are associated with adverse outcomes. This is from Bernardi and colleagues in 2015, where even an absolute change in postoperative creatinine of 0.3 milligrams per deciliter, which really ticks the box on both Aiken and KDIGO criteria for stage 1 AKI, is associated with about a 29% mortality. And in addition to that, having a stage 1 AKI could progress into stage 2 and stage 3 AKI, which carries with it a much higher risk of mortality and morbidity after surgery. And you can see here the frequency on this graph here, the frequency with which people experience bumps in their serum creatinine. We look at that sometimes as being fairly transient in the postoperative setting, but you can see its impact over here, the number of people that have bumps in their serum creatinine versus this line that's telling us that the higher the bumps in creatinine, the higher the 30-day mortality. So this has substantial impact on the outcome and the quality of life of the patient afterwards. This is more recent data taken from a multi-center observational study across 5 different programs across the world. And this was nearly 7,000 patients that were studied looking at the KDIGO criteria for AKI. And this was astonishing to me that across these 5 centers, that they estimated that 81% of their patients experienced stage 1 KDIGO AKI. And you can see here that if they didn't have a diagnosis of AKI, their incidence of major acute kidney events was about 4.5%, and then it carried with it about a 2% mortality to 180 days. But look what happens when you have both stage 1 AKI and stage 3 AKI. Stage 1 AKI, that increased about 3-fold to about 15% of a major adverse kidney event and carried with it about a 6.5% mortality. And certainly stage 3 being almost dialysis dependent here, you can see that the mortality at 180 days post-op was about 33%. If that doesn't move you in terms of considering oxygen delivery, then certainly your administrators would be interested to see the data in regards to the financial impact of an institution. And so this was taken from a national inpatient sample registry review looking at about 1 million patients that underwent cardiac procedures from 2008 to 2011. And about 10% of the patients that they studied experienced some degree of AKI. And if you looked at the univariate analysis in terms of the cost of caring for somebody in that index hospitalization, you can see if they didn't have AKI, that was about $38,000, but it nearly doubled for a diagnosis of AKI of about $77,000. And what the authors of this publication, it had indicated that, if there's a 10% prevalence of AKI after cardiac surgery, if we were able to avoid, just a 10% reduction in people experiencing AKI after surgery, it's about $100 million savings across our industry. So there's really vested interest in not just improving the quality of patient care and outcome, but the financial health of an institution. And so the idea of measuring oxygen delivery was really brought about initially by Marco Ranucci and his group, his colleagues in Italy, Milan, Italy, in 2005. And really, what they looked at was the association between acute renal failure and oxygen delivery. And really, what I try to focus on with the students is that it's not really getting rid of what we've already learned about the idea of venous saturations and serum lactates, or pump flow or hematocrit. It's really just adding to it, right? It's taking some of these components together, and you can see in the middle here with this ROC curve, this receiver operator characteristics, that DO2, especially a DO2 in this publication of 272, was more predictive of AKI than hematocrit alone. And this bar chart that's over here on the left, you can see the populations of patients that had the highest need for renal replacement therapy, that they were become dialysis dependent, were those individuals who had a high hematocrit but low oxygen delivery, meaning that they would have lower pump flows, or those individuals that have low hematocrit and low pump flow, low oxygen delivery. And so this idea that we're going to shift the paradigm a little bit, not to just focus primarily on what your prescriptive pump flow is, or whether you're maintaining your institutional hematocrit, but putting those pieces both together. And, we talk a lot about, in terms of the kidneys being ground zero, in part because even when kidneys are normally healthy, that what you find happens is that even in the deepest parts of the renal medulla, under normal circumstances, you see that oxygen tensions can be in high single digits. And then when you have a reduction in blood flow, or perhaps reduction in hematocrit, oxygen content, or even, a reduction in terms of hypoperfusion, that it carries with it, a pretty substantial risk of kidney events. But I also want to mention that thinking about oxygen delivery as a whole body response, that there is data that's emerged over the last couple of years with respect to oxygen delivery and its association with postoperative delirium. And so this was a paper that was just published 4 years ago in 2018, where they studied 357 adult patients that underwent CABG surgery. And this was an observational study looking at the association between nadir index DO2 and the association with postoperative delirium. And they found that even patients that of older age were more sensitive to delirium when they had a declined or a decreased oxygen delivery. And then over here on the right-hand side, this comes to you from, this was a 2021 publication from the University of Pennsylvania, where they looked at the relationship between low DO2 and mortality and morbidity following cardiac surgery. And this was about 850 patients. And what they found was that considering a DO2 of less than 280, that area under the curve was independently associated with not only AKI, but prolonged ventilation greater than 24 hours, and a glomerular filtration that was less than 65 mLs per minute. So it's not just the kidneys, it could be other end and target organs that are affected by low DO2. And I also want to make this discussion, a little bit more broad in terms of some of the risk factors unrelated to oxygen delivery that have an effect on maybe some goal-directed parameters. We think about oxygen delivery, but what is a target mean arterial pressure index? What happens when we lose pulsatility during bypass with laminar flow, or the way in which perfusionists manage temperature and rewarming and hemodilution? And so we know that the kidneys are susceptible to things other than oxygen delivery. This was a paper now, probably 12 years old, from Kanji and colleagues, looking at the differences of mean arterial pressure during bypass relative to the baseline pressures that patients had coming into the room. And you can see with the logistic regression models that they found that if there was greater than a delta mean arterial pressure of 26 millimeters of mercury from pre-bypass onto bypass, that carried with it almost a threefold increase in the risks and the odds of acute kidney injury. And then you can see here, when flow was established on cardiopulmonary bypass greater than 54 milliliters per kilogram per minute, that actually had a protective effect in significantly reducing the degree of somebody's odds of somebody receiving AKI. So pressure plays a role in this, as does pulsatility. And some of the pulsatility is a little bit more argumentative in terms of their findings. Coulson and colleagues in 2020 looked at a before and after single study analysis and found really no association between the risks of AKI and laminar flow. However, other studies have emerged. This is a randomized controlled trial, albeit a fairly small one, and they found that pulsatile perfusion during bypass was associated with a lower indexed SVR and PVR, with the idea that when you institute laminar flow, that the body's response is to create more catecholamines because of that loss in pulsatility. And then Nguyen and colleagues just last year, looking at the association between the loss of pulsatility in endothelial cell models, human aortic endothelial cell models that were cultured, indicated that there was less pro-inflammatory mediator response when pulsatile flow was used as opposed to laminar flow. Temperature management. In temperature management, Rob Newland and Rob Baker did a great analysis across the Perfusion Down Under registry, looking at cabbage valve, and cabbage surgeries, about the rate of rewarming relative to somebody's risks of receiving AKI. And what they found was that the duration of perfusion support at a temperature greater than 37.0 degrees Celsius was an independent predictor of AKI. And so this is one of those perhaps, goal-directed parameters that we as perfusionists have a lot of control over. And you can see the adjusted odds ratio of individuals who had a perfusion hypothermic time greater than 10 minutes. So a 51% increase in the odds of somebody acquiring AKI just from warming a patient greater than 37 degrees. And then lastly, with respect to hemodilution, and so again, Marco Ranucci's group looked at the impact of hemodilution in AKI, and this was, an analysis that they looked at in terms of trying to minimize the degree of hemodilution through the cardiopulmonary bypass circuit. So using integrated oxygenators and filters, sizing down both the diameter and the lengths of some of their lines, using centrifugal heads, just trying to find a circuit that was more miniaturized and biocompatible. And you can see the changes over time periods with nadir hematocrit on bypass and the AKI. So this was stage 2 AKI that they reported on. And then lastly, with oxygen delivery, the GIFT trial, as you know, was a multi-center, 10 centers across the world had participated in the study, looking at a oxygen delivery of 280, an index oxygenator of 280, and the association with AKI. And they found that there was a significant reduction In stage 1 AKI, when using a protocol that incorporated a DO2 of at least 280 on bypass, however, they did not complete this study, and so therefore it was underpowered to determine whether or not it would have an impact on more severe stage 2 and stage 3 AKIs. So all that being said, the data is there. The data is pretty compelling. And as somebody who's kind of drank the Kool-Aid over the last several years, watching some of my colleagues do some great research work in this area, it got me to thinking, how can programs look to address oxygen delivery as one of those, quality improvement or quality indicators for adequacy of perfusion in your own programs, right? And, it really starts with the ability to identify and secure the tools to be able to collect the data, right? And so some of this I'll share with you, obviously, is more conducive if you have, automatic data capture or electronic medical records in your practice, but there are ways for you to still get involved in measuring or benchmarking DO2s, even if you're still manually charting with paper. So I'll go over some of those opportunities here in the moment, but you can take this data back to key stakeholders. So this could be a quality improvement project that's multidisciplinary in nature, because ideally the team has to be there has to be this team concept, and it can't be just things that perfusion does, that anesthesia, surgery, and the nursing colleagues are all involved in this opportunity to do quality improvement. To me, this potentially can be fairly low-lying fruit. And there's a lot of data that's been published, over 15 years about quality improvement projects for perfusion, CQI. Rob Baker and Rob Newland published in 2008, looking at about 8 different parameters, bypass parameters, how they could, capture this data, report it back to their teammates during their departmental meetings, and then using that data to help, guide and improve future practice. And they were able to demonstrate, you can see through these statistical run charts with the confidence level intervals. I think this one is, avoidance of an arterial outlet temperature of greater than 37.5 degrees, that getting that data back into the hands of care providers not only helps with improving the adherence to their protocols, their clinical practice guidelines, but it helps with interdepartmental variation within practice. And so, you're finding that there's a tighter, there's a tighter compliance limit in terms of variation between providers. And Al's done some great work in this area. This was published in JECT in 2009, and him and his team developed 27 core measures and took that data that they collected, from these variables and discussed it again at monthly meetings. They're able to show, decrease in variation that exists across their team. And then lastly, Tim Dickinson and colleagues, this was published just a couple years ago in JECT, about the association between net prime and the risks of transfusion. And they found that the lower the index net prime was, that the lower the adjusted intraoperative RBC transfusions. And they concluded with a recommendation that net prime should be adopted as a national quality measure. And in the state of Michigan, that's one of the measures that now they're following, that, they have 34 centers in the state of Michigan that are now looking very closely at net prime, index net prime, according to their blood transfusion practices, and sharing that data across, key stakeholders across that whole quality collaborative. So in order to do this, you need to know, or you need to establish, first of all, how you intend to monitor oxygen delivery during bypass, what type of technology you're using, the formulas that are being used, how there could be variations within measurements, and then, more importantly, collecting those outcomes and, being able to use it to drive change. So here is some of the technology. I don't think this is an all-inclusive slide of all the various technologies that are commercially available, but some of these automated capture systems could at least take the parameters from the heart-lung machine and calculate DO2. Some of them can also directly measure DO2 VCO2 ratios through capnography. So whether it's incorporated into your perfusion EMR or using as a point of care inline monitoring device, or even in a system like Epic where it can harvest your pump flow and your hematocrit from your inline blood gas monitor and calculate that value for you. But like I said, if you don't have that technology, you're not an EME user, about 50% of us in the United States do not currently have, a perfusion EMR. So there's still ways to be able to record these values or take these values and incorporate them into your practice. On the left-hand side here, you can see an image of what's called a perfusion care plan. I think Bob Groom and his former colleagues at Maine Medical Center, developed this tool. So, prior to the procedure, they can put in some of the data that you see in red here, which is patient-specific data, type of procedure, patient's age, their height, their weight, their starting hematocrit, the static prime of their circuit, even the surgeon that's going to be doing the case if there's variations within how the perfusion is sets up. And it can calculate for you based on various hematocrits what your resultant pump flow should be on cardiopulmonary bypass. So this is assuming, of course, a DO2 of 272. So you can have this as part of your framework. Here is another example on the right-hand side, and this table set up to maintain a targeted DO2 of 280, an index DO2 of 280. So if you come over here to this column and you find your patient's BSA, and then determine what your hematocrit is on bypass, let's just say hypothetically it's 24, so you have a BSA, patient BSA of 22, hematocrit of 24, you would expect to be at about a pump flow of about 5.2 liters per minute. So you can use this as, as a guide in, targeting your blood flow and, potentially even document this variable on your perfusion record. And if you do, whether it's every 10 or 15 minutes, you're able to document these values, then you can go back after the case, enter this into a spreadsheet, for example, simple Excel spreadsheet, and you can follow nadir, index DO2 or maximum or mean DO2s, across perfusionists across your practice, and be able to benchmark those values and whether or not you're making successful changes across your team. Now, again, it's the limitation here is that you don't have the area under the curve or the time dose response. How long were you under that 280? How significant were you under when you were under? And so you don't have some of those capabilities that the automatic data capture people do. However, it's a great start, right? It's a great start to be able to benchmark data collection. This is from Makita and colleagues. This was in 2021, and this was 112 patients, and they analyzed perfusion parameters every 20 seconds during bypass, and they were able to demonstrate that while the nadir DO2 did not statistically change between those individuals who developed AKI and those who did not develop AKI, what you found to be significant is both the area under the curve. So they use 300 milliliters per minute per meter squared as their index, and the time that they spent under 300 were statistically significant. So you can see here in this ROC curve that nadir DO2 was not very predictive of determining whether or not somebody's going to acquire AKI after surgery. In fact, the area under the curve and the time dose response was more predictive. As you can see from this curve here, the straight line across, is essentially, a flip of a coin, better than just random guessing. So if it's on the left-hand side of this curve, it would be more predictive than, just taking a guess. So, having automated data capture, might be a benefit in terms of managing these patients and oxygen delivery. And if you don't have such a system in place, this might be an opportunity to do that, to ask for that. How about target DO2? The literature, ranges anywhere from 262 to 280, as you can see here. And it does make a difference, right? Because if you were to take a target DO2 of 262, presuming a hematocrit of 23, you can see with a BSA of 1.8 that target would be about 3.8 liters per minute. But if you're using 280 as your target, then you can see it's about 300 to 400 milliliters above that at 4.1 liters per minute. So as a team, you'll have to determine what your target is if you implement it. And there's some data that I think is coming that will be published soon. I know George Justison had presented at AMSECT a few weeks ago, about those patients that are at higher risk of AKI. Perhaps they have lower creatinine clearances prior to surgery, that 300 to even above 320 might be more appropriate for them. So I think the goalpost is kind of moving a little bit in terms of being more prescriptive of what that ideal DO2 is for patients. You also have to consider how it's calculated, right? So if you are using automated data capture like, LivaNova Connect system, you can see the DO2 calculation here incorporates dissolved oxygen and plasma, right? But if you use the spectrum for it, it does not. And you can see that the calculations are are performed differently depending on what they capture, whether it's hematocrit versus hemoglobin. You can even see the constants between the association between oxygen and molecules of hemoglobin are different. So you may wind up with different values across different manufacturing lines. If you're a roller head user, or you place your centrifugal flow probe prior to the most distal point of your circuit, you may be either under or overestimating your pump flow to the patient, right? So there's an AMSEC guideline 7.6, that says that, flow probes should be continuously monitored on the most distal part of the arterial line. So any shunts that might be open, whether it's sample manifold, whether it's hemoconcentrator, are taking into account, right? The last thing you want to have is, you're flowing at 4 liters, but you have 3 shunts open and you presume that you're meeting your target DO2. Also, with regard to how hematocrit's measured, is it a point of care handheld device like an iStat or an EPOC that we know, is not as accurate as our benchtop models in terms of the way in which it calculates hemoglobin hematocrit? Did you recalibrate your inline blood gas monitor if you're pulling your hemoglobin and hematocrit from your inline monitoring devices? Here, Jim Rager and colleagues, you can see here, the percentage of times that, between certain devices that they fell within that 1 to 2 grams per deciliter of hemoglobin. We can't assume that they're all measuring it the same way. If you do make changes to your practice in terms of oxygen delivery, that might mean that you're also needing to use or adjust your cannulas, both the sizes of your arterial or venous cannulas. And so surgery has to be intimately involved with, whether or not they need to make changes to their practice, having, the ability to flow a higher cardiac index. I struggle with this sometimes when it comes to robotics, and minimally invasive procedures using peripheral cannulation, and whether or not we're able to achieve, a 2.6 or a 2.8 index if we're using, femoral cannulas, or maybe having to incorporate more use of vacuum assisted venous drainage if you're not already doing so. This might be a little difficult to see, maybe perhaps more eye candy than anything else. but with regard to changes in hematocrit, right? So this line here would represent this blue line, somebody with a BSA of 1.8. So if my hematocrit was 21 on bypass, I'm looking at about 4.8 liters of flow or an index of 2.67. However, if my hematocrit was 24, for example, and now I'm looking at a plump flow of about 4.2 liters per minute or an index of 2.36. So it may change the paradigm on your management of blood transfusions or hematocrit. If you can't flow higher, is transfusing a unit of blood, the right thing to do. And, I think, probably a number of us probably have to reconcile with that fact that, incorporating DO2 the way that it's supposed to be performed, there might be some instances where you normally wouldn't transfuse according to your protocol, but your surgical team may consider it. And we've talked, mostly in this webinar about oxygen delivery, but there's another component here, right? The component is, the ratio between what the patient's getting versus what the patient needs, right? So serum lactates, one of those, good biochemical markers that we can assess during cardiopulmonary bypass to ensure that, there isn't anoxia that's taken place, systemically. But there's a delay between anoxic injury and serum lactate production. And you can see here a serum lactate here of less than 2, which we would consider to be fairly normal, right? But is there a better way to identify whether or not there is that shift to anaerobic metabolism? And so some of these parameters would be more patient-centered DO2 parameters. So the patients would kind of serve as their own control, right? That, even in the GIFT trial, there were still a small population of patients that had a DO2 of 280 on bypass in the interventional arm, but they still acquired AKI. So there could be circumstances where patients need more than 280. And so some of these respiratory quotient parameters like VCO2 over VO2I, or even DO2 over VCO2, you can see here on this table on the right that if the DO2 VCO2 ratio was 5.3 or above, that the risks of serum lactate production were a lot less. So if your program has the capability of looking at some of these parameters through capnography, for example, if your technology permits it, this might be a great indication as an augment to what you're already doing with oxygen delivery. And if you are using capnography, then even the formulas and the algorithms that are used to calculate those values can change between manufacturers. And it can also be affected by the design of the oxygenator in terms of the gas exhaust, right? What type of blender are you using? What type of oxygenator are you using? You can see, significant differences here. This was taken from some of Rob Baker's work in 2017, looking at differences between different technologies and how they calculate exhaust, CO2 exhaust from the oxygenator. And then lastly, I'll leave you with, how you can take the data that you collect and use it as a benchmark in terms of how you can associate this to perfusion outcomes, right? So if you belong to a perfusion registry, SpecialtyCare has this great scope registry. If you live in New England or the state of Michigan or in Australia, New Zealand, they collect perfusion parameters and then also collect patient outcome surgical parameters. And so they can see how discrete perfusion practices are associated with particular outcomes, right? However, if you look at the STS Adult Cardiac Surgical Database, they diagnose renal dysfunction or renal failure. The parameters that they collect are the preoperative serum creatinine, the greatest postoperative serum creatinine, and then they define acute renal failure as meeting the criteria that either your serum creatinine has grown threefold, that it's reached an absolute number of 4, or that they require renal replacement therapy. if we were to use the data that I took from one of the very first slides I shared with you in that population that had the KDIGO AKI of 81%, if we use that definition for the STS, only 4% of those patients would be identified. So it's really cutting out stage 1 and stage 2 AKI. So maybe, there should be an impetus for a program to closely monitor serum creatinine and just don't rely on one particular, database in order to determine whether or not, certain perfusion adequacy measures are being maintained. So in summary, I'd say that incorporating some of these oxygen delivery goal perfusion parameters is not an insurmountable goal. It can be done. And leveraging what we know about the published literature and what we have with professional guidelines to assist teams in, creating and maintaining these goals. And then, I'm a big believer in some of these, measuring some of these parameters with the focus on, improving or maintaining the quality of your program and the overall effectiveness of the care that we provide the patients every day. And so with that said, I so much appreciate being here with you today, and look forward to the panel discussion, even for some of you that might actually be, deeply immersed in this type of work that can share some of their experiences as well. Thank you.
That was wonderful, Dave. Really do appreciate it. And I like how you summarized by going back to one of your salient points that you made in regards to not having to have an automated data collection system. I think that's a key aspect in that so many people don't have access to some of these. At least in America, we know it's changing, but that's a great summary. And I think you said, a simple Excel sheet. Many have been developed throughout the United States and even abroad. So that's a great bring home point for all of us. So let's begin. And Alex, I would like if you to start with the questions and answers, and well, they would do the answers, you do the questions.
Yes, absolutely.
Thank you.
Thank you, Dave, so much for such a thoughtful presentation and for addressing such an important topic in perfusion. On behalf of SpecialtyCare and pretty much everyone in perfusion, we truly appreciate your devotion to our profession. So we will start our Q&A session. For those of you who have any questions, you can ask that in the Q&A bubble at the bottom of your screen. We do already have one to kick us off, and we'll just start there. So our first question, Dave, is the DO2 as important of a variable as the DO2-VO2 ratio, i.e. delivery and consumption? Might this not take into account changes in metabolism, sedation, etc. during a bypass run or while on ECMO?
Yeah, I see Bill's comment, and it's a very appropriate one. I mean, ideally, it would be great to have DO2 VCO2 ratios, so that way every patient serves as their own control, right? With DO2, we know what we're delivering, but we don't really know if we're meeting the patient's needs. And so if you have the technology to do that, that would be wonderful. Not everybody does. But if you leverage those opportunities and the technology is reliable in terms of what it measures and the design of the system, I think that would be a great adjunct into what you already collect on bypass. So yeah, it's such a great question.
Great, thank you. We have a few more coming in too. The next question is from Mark Lucas, and he asks, what have you reviewed in the effects of increased ADH during CPB causing renal hypertension?
Yeah, Mark, that's a great question. I'm not. I'd have to go back and think about that. Nothing comes to mind in terms of I know there is increased ADH, of course, during cardiopulmonary bypass, but I don't know. I can't think of studies in particular. I don't know if Alex or Al have any comments on this in terms of, some of the effects if you're combining that with oxygen delivery, or whether it mitigates some of the benefits of using that.
Yeah, let me follow up if it's okay with you,
Yeah,
Dave,
please.
on that. And several of the papers that you've cited, reviewed and you've stated it too, of course, in your presentation, the neuroendocrine response, which is what Mark is referring to. And one of the primary indicators that people are concerned with maintaining a mean arterial pressure, for example, and also blood flow, since it's going to be increased when you're trying to set a nadir DO2, either area under the curve or a single value, is the effect of vasopressor use. And I know a number of the studies have commented on this, that there's either been high or low vasopressor use once you're maintaining a DO2 at some level, let's say 280. And of course, this is what Mark is referring to, looking at an exogenous source of vasopressor. Can you comment on that? I mean, do these studies control with their logistical regression for vasopressor use, or is that something that we should be looking at in addition?
Yeah, no, one of the studies that I did cite, that was on the slide with pulsatile perfusion. They did find that, there was an increased pressure requirement in some of these circumstances. You would normally expect that there be more of a release of ADH and norepinephrine release during cardiopulmonary bypass, but I can't think of studies. I know they exist. A particular study that comes to mind where they adjusted for that.
Gotcha. Thank you, Dave.
Yep.
Okay, and so our next question, Dave, is from Jim Bikakis. All the flow and DO2 and numbers are with a set map of what? 60, 70?
Yeah, that's a great question. Some of the data that's been published would suggest that the mean arterial pressure should be over 55, at least 55. But even some of the data with respect to just looking at isolated blood pressure even varies. The degree of which cerebral autoregulation occurs, and even though that we may identify a pressure range from 60 to 80, that some people may need actually more than that. Depending on the degree of autoregulation that takes place, if they have certain pre-existing conditions. I'd say for the most part that many perfusion programs would somewhere, fall in line between that 60 to 80 millimeters per mercury. But again, as you know, it's not incorporated in terms of the oxygen delivery formula, right? It's, based primarily on oxygen content and cardiac output. And if you do find yourself with higher flows, then, I'd almost expect that there'd be an associated increase in blood pressure at higher indices.
They did a wonderful job of bringing up the multifactorial aspect of not only AKI, but other aspects of perfusion that could result in central nervous system dysfunction, delirium, or even multi-system organ dysfunction. One key that I'd like you to comment on is which Newland and their group and from Adelaide, and actually the whole Down Under group, identified that for AKI. But the clinical practice guidelines that I believe you were an author on, 7 or 8 years ago now with temperature management, really honed in on that and changed strategically how we manage perfusion. If you believe in that high level of evidence, clinical practice guideline of 37 degrees. Can you comment on that, in regards to what your thoughts are for temperature management, and should we be rethinking full rewarming with these patients, and also the rapid level of the rate of how we rewarm them?
Yeah, Al, that's a great question. I was not on the temperature guidelines. However, I shared some data with you from that particular paper, and most of those recommendations on that document were actually level C evidence, right? Because you're rarely going to find a randomized control trial where you institute hyperthermia in some patients versus a control. But I think your comment or your question about avoidance of hyperthermia or the rate of rewarming is pretty important. Retrospectively, I think Rob and Richard had published some of their findings from the PDU registry, but we also realized that some of the temperature devices, the probes that we use during bypass, sometimes underestimate the true temperature of the blood by anywhere from a half to a full degree. So if you think your blood's going into the patient at 37.5 degrees, it may actually be as high as 38.5 degrees. And we consider the arterial outlet temperature to be a surrogate for cerebral temperature. And so I do think that, it could have a significant impact in patient outcome. And not just that, but, trying to avoid, large gradients that exist between your venous and arterial temperatures. And, if you're rewarming, say, for example, from 32 degrees, that you really don't want that gradient, being larger than 4 degrees between those two temperatures. And so I really do think it should change our practice for programs if it hasn't already, based on the evidence that we know we do have.
Thank you so much for that, Dave. We have a popular question here from Matt, and the question is, Dave, in your practice, what would be your priority, not giving a unit of blood or giving a unit of blood in order to help achieve an appropriate DO2, assuming you could not increase your blood flow?
Yeah, damned if you do, damned if you don't, right? Like, if you don't have the DO2 that you're looking for, then you run the risks of AKI, right? But if we all know that giving a unit of blood can also increase somebody's risks of AKI. So I think, to try to sidestep this question as politically capable as I could be, I guess it would depend on how far off am I from my target? If I can't go up any higher on pump flow, and there are no other variables that I can, manipulate, temperature, perhaps, if it's a arterial cannulation problem, if it's a, venous drainage problem, and I can't, fix it by improving venous drainage, probably say that I'd probably lean more towards giving a unit of blood if I really needed to. But at my center, DO2 doesn't always drive whether or not somebody's going to need a transfusion. So we're following it, but my center might not be as prescriptive of using DO2, as opposed to some other centers that, that's the primary variable that they follow during cardiopulmonary bypass. So I think, it's probably based on what your protocols are at your institution and, what the surgical team thinks would be the best for that patient at that given time.
Thanks, Dave. I'm going to follow up with your thought there. And this is from an anonymous attendee, talking about red blood cell transfusion. Are you aware, perhaps the Perfusion Registry, which you're very knowledgeable out and have used extensively, has anybody looked at registry data from when a DO2I protocol was initiated and, standardize it to a particular procedure type, first-time coronaries, for example, and look at the change in transfusion that has occurred? This is coming from the anonymous question. Before they started the protocol and then after, to see if perhaps there is an influence, as several have pointed out, with increased transfusion.
Yeah, it's a great question from the anonymous person. So to be specific about the Perfusion Registry, they do not collect DO2 in their registry. So probably have to leverage another registry, another center for that. I think that would be an interesting analysis, whether or not incorporating a DO2 driven perfusion protocol increases a program's usage of allogeneic blood products. I think it's a great question. I just couldn't answer that with what we know we don't collect from Perfusion.
Alex, if I could follow up, a quick question for Dave. Dave, area under the curve versus DO2 nadir.
Yeah.
Do the electronic data collection systems have the ability to integrate area under the curve so they can provide that metric, or is it still just nadir D.02?
Yeah, that's a great question, Al. I believe some do. I vaguely remember, at a recent meeting, Jimmy Beck from Columbia sharing some of their data that they collect. I think they use the quantum system, and I think they collected some data, area under the curve, or TDR, I think. But looking at that cumulative effect, I'm not sure all systems can do it, but I think some of the more sophisticated systems, the newer systems, have that capacity to do it. I think it's hard to calculate. It's not an easy parameter to measure.
Good point. Well, we're just, Alex, do you have another question? I didn't want to interrupt you there. I saw you unmuted.
Nope, I'm all good.
All right, excellent. Dave, we're at the top of the end. It always does. There's more questions that require further thought, and you did a phenomenal job of instigating in all of us a desire to learn more about this. And I think we're going to address this again. Hopefully you can come back and talk about other issues with the adequacy of perfusion. You started talking about them with lactate acidosis, lactatemia, and there's others that we could then spend some time chatting with. But if you don't mind, we're going to hold off since we're at the top of the hour. I'm going to put a plug in for our next presentation, which is going to be Shannon Barletti and Tim Bazzelli, both traveling perfusionists, and they're going to talk about what it's like to be a per diem perfusionist. Recent information published in the nursing realm about it has the bubble burst in regards to per diem nurses. This just came out today. So it'll be interesting to see what these individuals and all the attendees state afterwards. That's going to be June 15th. And then here's Dave's email. Right now, you can find it easily on the web, of course, but please don't hesitate to reach out to Dave. He's a phenomenal communicator. It's amazing how quick he responds. As busy as is. Alex is here as well, and mine. So if there's, I got an extra S in mine there. So probably, go ahead and use Alex if you're not getting your certificates. But I want to end by thanking Dave, thanking Alex, and thanking Maggie, who coordinates in the background these webinars. And I appreciate everybody attending tonight. It's always intriguing and exciting to hear from these very, very learned people. So with that, I'm going to thank everybody and wish you all a good evening.
Thank you all.
Take care, everyone.